Hi, I'm Kelly Garcia, and I have the honor of serving the state of Iowa as the Director of the Health and Human Services. We have a number of significant initiatives underway, all of which are focused on better serving the Iowans who depend on us. While this initiative is a bit more technical, it's absolutely critical. I often talk about Medicaid as the backbone of our agency, and this Medicaid systems modernization effort is key to ensure we're driving on outcomes and moving our Medicaid program forward. I am proud to introduce our Medicaid Director, Liz Matney, to announce the launch of our Medicaid Modernization Initiative.
Thanks, Kelly. I'm Liz Matney, and I am honored to serve the State of Iowa Department of Health and Human Services as the Medicaid Director. Our mission is to work to provide our Iowa citizens with equitable access to high-quality services. Services that promote dignity, remove barriers to health engagement, and improve whole person health across populations. We are launching a Medicaid systems modernization effort to transform our existing systems and business practices from today's current state to a better, more effective future state. We are excited to get started because our current state environment is overdue for modernization. With this introduction video, I am hoping to generate engagement and interest from our vendors and stakeholders who share our vision and are best equipped to help us deliver it. We have been in a planning phase to determine our starting point for our modernization efforts. Something I feel is very important is gathering feedback from the people closest to the problems. We started by talking to our internal staff. The clear theme we heard from our staff was the need to provide better support through technology to our provider community, who are on the front lines of providing services to our members. We drafted a list of provider outcomes and surveyed our provider community about which outcomes were the most important to better serve our members. However, as we began to baseline these outcomes, we quickly realized we are impacted by an inability to organize and analyze the information we require to improve the outcomes. In many cases, we were unable to extract reliable data to understand our current baseline measures. So our first step in prioritizing the initial outcomes was to determine which outcomes we could focus on to best drive data quality improvement, which in turn will set the stage for delivering all the remaining outcomes. We concluded the best place to start is with provider enrollment and credentialing, re-enrollment, and provider information maintenance. Our team created several informational videos like this one to provide additional details about our current state environment, our CMS certification approach, our implementation approach, and our initially prioritized outcomes and next steps. Please check them out and join us in our modernization journey.
Hello, my name is Anthony Lyman. I'm honored to serve the state of Iowa in the capacity of Chief Information and Technology Officer for the Department of Human Services. If you watch the introduction video by Director Matney, you are aware of our Medicaid Modernization Initiative, starting with provider enrollment and management outcomes. I'm focused on ensuring our modernization efforts are taking advantage of modern technology, which is advancing at an ever-increasing pace. We have a risk of making improvements that attempt to produce a newer version of our current state. Liz and I are highly aligned on achieving a loftier goal with modernization, which perhaps may not look anything like our current worldview or experience. I'm excited to embrace this challenge and take this opportunity through modernization to dramatically improve our ability to serve Iowa citizens. Our modernization team has been assessing our systems environment to understand the current state and determine the best approach for modernizing. First, let me provide a bit of background on our current state environment. Many of the systems we use today were built in the 80s and 90s, and many are operating on mainframe technology. A good amount of Medicaid processing still runs on our core MMIS system, which was initially developed to manage Medicaid member and provider information, process prior authorizations and claims, manage third-party liability, and support reporting and other administrative functions. We've continued to add and integrate systems over time as new laws and policies are enacted. including the creation of multiple sources of eligibility data, a system to manage premium payments, a system to handle waiver and long-term care case management, and an informational portal for providers, an eligibility portal for members, multiple systems for managing workflow and documents. We also have commercial off-the-shelf products implemented to manage program integrity in pharmacy, point of sale, drug rebate. We have over 20 systems we maintain as part of our Medicaid enterprise system architecture, operating on a wide variety of underlying technologies. Each operational system is programmed separately with our business rules and stores data independently from other systems, creating opportunities for business rule and data discrepancies in our environment. To keep all of these systems coordinated, we maintain hundreds of data exchange interfaces and also created a data warehouse where we consolidate data extracts from each of the operational systems. Unfortunately, it does not currently support data quality management, reference data management, or master data management functions. As you might imagine, the resulting environment becomes more and more challenging as changes continue to be layered on top of old technology. Our ability to respond effectively to business changes continues to degrade. New laws and changes in policy are often addressed by the addition of new systems, data sources, siloed rules processing, and data exchange interfaces. In 2016, we made the transition to managed care. The previous picture we just discussed comprised the full extent of our Medicaid enterprise systems. We also have other DHS enterprise systems integrated with this environment, as well as external systems. Adding the MCOs created additional data exchanges for member eligibility, provider enrollment, and encounter data. We later split out dental coverage to be handled by prepaid ambulatory health plan payers. Okay, so the big question is, how do we go about modernizing something like this? We've been working with CMS on certification approaches and put together our thoughts on an implementation approach. Please review the remaining informational videos for more information on our planned approach.
Hello, my name is Stephanie Clark, and I am the Acquisition and Certification Manager for the MEAM program. I am responsible for the coordination with the Centers for Medicare and Medicaid Services, or CMS, the primary funding stakeholder behind Medicaid systems enhancements. I ensure our funding requests and certification processes are aligned with CMS compliance rules. Additionally, I am responsible for coordinating our program acquisition activities. As you heard in the previous two informational videos, we are launching an effort to start modernizing the current state picture Anthony laid out. This is an elephant-sized problem. An elephant we'll call current state elephant. CMS has been working with all 50 states on the best approaches for modernizing for several years. Prior to 2016, the most prevalent method of modernizing was through a Big Bang MMIS replacement project. This involved the release of an RFP to buy a single automated solution to replace as many old systems as possible in one fell swoop. So essentially replacing our entire current state elephant with another, hopefully better elephant. These projects were high risk and high cost, often in the hundreds of millions of dollars range, and often resulting in failure, significant cost overruns, or sometimes both. In 2016, a CMS final rules established new expectations for how states could modernize. CMS recognized the risks and challenges associated with large procurements and provided guidance directing states to deliver modernization by breaking down the enterprise systems into modules and steering away from monolithic system deliveries. The updated guidance allowed states to certify modules independently, because everyone knows how one is supposed to eat an elephant, right? One bite at a time. The theory being to take small module-sized bites out of the elephant by replacing each subsystem independently in an incremental fashion and integrating them into the architecture with a system integration layer. This new rule included a certification approach, allowing states to independently certify modules demonstrated to meet CMS's certification requirements. Certification is important because CMS funds the operations of certified systems at a higher federal financial participation match rate than uncertified ones. This allows states to remain certified while modernizing one module at a time. Iowa has been evaluating modularity-based approaches and has struggled to identify a clear path to modernization through the replacement of individual systems or modules incrementally. We believe this is for two primary reasons. First, if we look back at the business outcomes Liz mentioned earlier, we find them to be the result of end-to-end business processes traversing across several systems in our environment. The replacement of a single module may not result in an outcome improvement unless the other modules are also modernized concurrently. If the goal is delivering value through technology to address Medicaid's highest business priorities, we do not see a path to achieve this goal in the near future through the traditionally defined module strategy. Second, the 2016 Modularity Rule Guidance included 600 certification requirements mapped to 10 MMIS modules, referred to as the Medicaid Enterprise Certification Toolkit, or MECT. The MECT requirements structure further reinforced an approach focused on system replacement. However, as Anthony alluded to earlier, our analysis has shown us that the technical environment surrounding our systems and how we interact with that environment is the primary inhibitor of our ability to achieve business outcomes, not necessarily the systems or technology. In addition, we found the organization of our current state systems did not match up well with the MECT module structure, limiting our ability to identify straightforward module replacements that aligned with the certification model. Fortunately, CMS is pivoting away from the MECT certification model and is instead focusing on outcomes. CMS recently published guidance announcing a streamlined modular certification, or SMC, process. SMC continues to leverage a module construct, but has simplified the 600 MECT system requirements down to around 140 system outcomes, which are proposed for system certification. More importantly, CMS established guidance for states to develop program or business outcomes that provide the direction and priority for delivering the CMS system outcomes through modernized solutions, and are the primary basis for ongoing certification. Even more significantly, states have the discretion to choose which CMS system outcomes are included for consideration when delivering the program outcomes and certifying the corresponding technology solutions. These changes in guidance open the door for mitigating the two major challenges we've faced planning for modular delivery. We can now focus on the outcomes from the business as the primary drivers of technology modernization, aligning our IT work closely with our Medicaid business's most critical needs. In the next informational video, we'll lay out how we plan to align our implementation strategy with the updated guidance from CMS.
Hello, my name is Kevin Sutherland. I am honored to serve Anthony, Liz, and their teams in the capacity of the Modernization Program Manager. My primary role on the team is keeping our focus on the highest priority business outcomes from Liz and her business owners, and facilitating the delivery of these outcomes in the most effective way possible. Under the new outcomes-based guidance from CMS that Stephanie just described, we revisited the technology implementation strategy and concluded our best chance of delivering value for the business will be achieved not by exchanging our current elephant for another different elephant, or by taking small bites of modernization out of our current state elephant, but by raising a new, super modernized elephant, one business outcome at a time. An elephant that is free and encouraged to grow up to be a very different elephant from its predecessor. The technical complexity of modernization is overwhelming. This approach allows us to start with scope broken down at an achievable level to limit the business complexity to a bare minimum while we experiment with the correct technical approach until we get it right. To give some context, let's take provider enrollment as an example. We currently have in the neighborhood of 100 different types of providers coded in our MMIS. For each provider type, we collect different information and apply different business rules during the enrollment process. Providers currently submit the applications via mail, fax, or email, which internal staff key into our mainframe, and the resulting data is propagated to other systems in our environment, our managed care partners, and often combined with other data, resulting in numerous outputs.
For example, our MMIS team generates and sends the monthly TMSys file to CMS. The file is comprised of data from several domains in addition to provider.
Our new elephant approach enables us to start with one provider type or one transaction type, something small in scope. We can configure a technical solution to deliver the outcome for that provider type and demonstrate it to users quickly. And by quickly, we are hoping this means we measure time in days or weeks as opposed to years. Since the largest number of new applications on average come from physicians, we might choose to start with physician applications. Or maybe there's a specific provider type experiencing major challenges with the enrollment process, and the business decides to prioritize that one first. Either way, the business is in full control of prioritizing the sequence of the work. Our job is to get each type working as soon as possible to evaluate the outcome. And note the definition of working also means we send back all of the information from the new process that the current systems require to perform all other business operations. We expect to learn significant amounts of information when we start processing applications in the new environment. It's even possible we realize we've chosen the wrong solution and need to go back to the drawing board, or that we need to pause to resolve a major issue. But it's important that we figure that out in weeks, rather than getting to the end of a large 2-year implementation only to realize our initial assumptions were faulty and we've fallen short of the outcomes we intended. Once we've seen an end-to-end process working in a production environment, confirmed the solution achieves our business outcome expectations, have received positive feedback from the provider end users, have confidence in the quality of the solution, and have demonstrated we can support business operations on both elephants simultaneously, now it's time to scale. Next, we can add another provider type, then 10, then 30. With all of the issues resolved and learning incorporated after each iteration, we anticipate building momentum exponentially until all provider types are working in production. With all business transactions transitioned and working through the new solution, the previous entry point for application processing can be turned off. And while the older systems are still functioning based on provider data limited by the constraints of those systems, we now have a rich data set being compiled in the new system, structured to support advanced analytics from the data we receive. With this approach in mind, our business team has been working to prioritize the target business outcomes and determine next steps. Review the next informational video to understand how to engage with us as we launch this effort.
Hi, my name is Bob Schlieder. I am the business owner for the modernization effort, and I have the primary responsibility for prioritizing and decomposing our target business outcomes for the team. I will be walking through the outcomes we've prioritized as a starting point for our effort and provide examples of the pain points and improvement ideas we've received from our providers as the top priority items. As you've heard from Liz in the introduction video, we are launching our modernization efforts with an initial focus on provider enrollment, credentialing, re-enrollment, and provider information maintenance. The provider enrollment process is the entry point for providers wishing to serve Medicaid members and can be leveraged to enforce data quality standards and rules. Our current systems provide little in the way of structured data entry and do not enforce even basic data integrity relationships. For example, our system has a name field which is used to capture first name, last name, organization name, really anything you want to enter into a single open text field if you can believe that. Modernizing the enrollment process will set the path for collecting and maintaining clean, organized data from our providers. For the provider enrollment outcome, we've defined 2 success criteria for assessing how well we've achieved the desired result. 1, reduce the effort required from providers to complete the enrollment process from start to finish. And 2, reduce the elapsed time it takes providers to complete the enrollment process from start to finish. Both success criteria consider the entire process, which includes any steps providers must take to become credentialed with managed care payers. However, since we prioritize the improvement of our provider data quality, we plan to focus initially on the Iowa Medicaid enrollment portion of the process. To understand our baseline performance against these success criteria, we ask providers to estimate the amount of effort they spend going through the enrollment process and pulled processing time data from our enrollment application processing system. We found on average that providers spend 5.5 hours getting enrolled with Medicaid and 6.2 hours completing the credentialing process with managed care payers. On average, over the past 3 years, the enrollment process takes 40 days from application submission to approval. Credentialing process times average around 8 days over the past year, not including the time required to establish contracts. Keep in mind these are aggregate metrics across all provider types and scenarios. Please reference the Medicaid Modernization website for access to the full baselining dashboard showing provider enrollment volumes and the baselining metrics broken down by provider type. To determine solution ideas most likely to improve these two success criteria, we held listening sessions with providers. Here are some of the feedback points we captured. 1. Improve the application process and information available to providers about how to enroll. Our current enrollment form was designed to be universal, which means all information and data fields are presented for all provider types. Really, a subset of the application is relevant to each provider, and the application also must be manually filled out and emailed, mailed, or faxed to us. Providers do not have a visibility into the status of their application and often end up calling provider services to determine where they are at in the process. With an automated solution, we can easily create an online wizard-style process that clearly lays out exactly what is needed from the provider based on their provider type and ask them only for information we need to process their particular application. We can also give providers the ability to look up status of their application, to understand where they stand in the process, as well as notify them automatically when action is needed or when status changes occur. 2. Take advantage of automation opportunities. In many cases, providers provide insufficient or incorrect information with their application, resulting in delays while our staff request corrections and supplemental information. We can automate validations and lookups to save providers time when applying and prevent back and forth with staff. A third area was to integrate Medicaid enrollment with other payer enrollment to streamline the process. Providers must currently provide the same duplicate information to NPES, Iowa Medicaid, and each payer they want to credential with. A new solution could reduce provider effort by retrieving and/or passing on information provided to other payers where possible. There are also several internal factors we must consider in pursuit of this outcome and our goal of improving provider data quality. In our current systems, we did not establish a guaranteed method of identifying a provider between systems. We believe the standardization and implementation of a provider identification system is needed in our new solution. Further exacerbating our data quality issues, even if we can match provider records between systems, there is no standardization between how Iowa Medicaid captures taxonomy or service information from providers and how the MCOs capture it. The same provider may be given different options to select when applying in each system, creating discrepancies. We believe standardization is also required for taxonomy and service types as part of the modernization effort. We anticipate both of these standardization activities to require coordination and crosswalking back to our existing data to ensure we don't negatively impact business continuity on our existing systems. Our analysis indicates it will be unlikely we can easily change reference data values in the current state systems without refactoring those systems. Lastly, in the cases in which staff intervention is required, a clear, easy-to-use, and easy-to-track process is needed to ensure staff can manage their enrollment workload and quickly take action to complete any manual steps required. In alignment with the new elephant approach that Kevin and Stephanie described earlier, we have been working to identify a first category of providers with whom we can partner as we launch our first modernization initiative. We've decided to begin with our physician population and have captured the current state process steps and business rules applicable to physician providers. Additionally, we've established a work group of providers who are engaged and excited to work with the delivery team on the best methods of achieving our provider enrollment outcomes. I'm looking forward to launching this initiative.
Liz here again. I can't agree more with Bob on how excited we are to begin our modernization effort. I'd like to talk a bit about our next steps, which include beginning our engagement with the vendor community, who we hope can bring us innovative solutions and highly skilled practitioners to start raising our new elephant the right way. We recognize we are not experts in modern technology or the latest software integration and development practices that optimize flexibility, adaptability, quality, and the successful delivery of business outcomes. We also recognize the complexity and unknowns present in our current state environment, which limit the ability of outside experts to confidently recommend solutions. We have the following activities planned to reduce both of these current knowledge gaps. First, publishing our modernization website, including questions and answers from vendors and a documentation library. Second, issuing a request for information seeking solution suggestions from the vendor community that are best suited to deliver our outcomes. And third, holding vendor conferences to facilitate an open, collaborative exchange of information with the vendor community. We hope we can quickly achieve the knowledge required to move forward with our first delivery initiative. I'm looking forward to it.
We are excited to launch this modernization initiative and see the outcomes from our upcoming collaboration and innovation. I love the idea of raising a new elephant as quickly and responsibly as we can. Liz and her team have my full trust and support, and I can't wait to see our results.